The Heart Demystified. Smarter Heart University and Dr. Scott on AM 970, The Apple.
Welcome back, folks, to your Smarter Heart University. Dave, thanks for staying on the line and talking with us.
Sure.
I think we got cut off the last time I gave the pop quiz. Just in case, who does worse with atrial fib in life and death or stroke, men or women? Actually, women have a higher risk of stroke with this arrhythmia. They are more symptomatic with it. They actually fare much worse on the anti-rhythm control medication, such as what Dave is on, to suppress the rhythm or convert it. And they get referred less for the invasive cures, such as ablation, which we're going to talk about this segment. The issue is who is the best candidate for the ablation. Do you get a lot of questions about this on your forum, Dave?
Yes, we do, and there are a couple members that have been through the ablation process not once but twice, and have under the discussion tab have extensively shared their experiences with us, and it's kind of remarkable. Sometimes it's a success, and sometimes it's not.
Yeah, that's really good. It's a good lead-in. Basically, if you can't tolerate or you fail the medications and you go in and out, and it's important to point that because that's where the best people do with this procedure, and it is an invasive procedure. Dr. Kaiser is going to talk about it. You go in and out of atrial fibrillation. A newer but now well-studied and well-performed procedure is called radiofrequency ablation or cryoablation. Ablation has been used on lots of other abnormal electrical rhythms, especially in children with high 98% success. And it offers the benefits over the drug therapy in selected patients. And I got to stress, selected patients. Basically, what they did was they discovered that the rhythm originates from two veins coming in from the lungs into the left atrium, that small chamber I talked about in our first segment. By zapping those, by frying them, by freezing them, however you want to put it, it's a big leap forward in obliterating this arrhythmia. In perfect patients, and I stress this, the success rate is about 80 to 90%. But what Dave just pointed out, 10 to 40% are going to require repeat attempts. Do you want to discuss how it's done?
Sure. The procedure is for lack of a better term, it's a heart catheterization. The electrical doctors or cardiologists who specialize in the electrical system of the heart enter a vein down in the groin and with a catheter, which is probably about the size of an inside of a pen, go up into the right side of the heart, then cross across a piece of tissue called the intra-atrial septum. It's a piece of tissue that separates the right and left side over to the left side of the heart. And then again, using a special catheter that cools, essentially freezes the tissue from the inside out, and special high-tech mapping systems. It's very gee whiz kind of stuff. These pictures that they produce with this stuff find where these veins are and essentially cut the wire between the vein and the atrium, hopefully disconnecting where this atrial fibrillation is coming from by creating a little burn, a frostbite burn from the inside out. And about 70% of the time it's effective with one shot, and the 30% that don't end up going back a second time, and of those, about 70% get effective as well.
And actually, just to add to that, in our experience and our electrophysiologists, our electricians, we're the plumbers, and there's electricians and carpenters and contractors in the heart field. You get this procedure done, and they want you to really wait 3 months. So a lot of people have to come in. They're still on medications. They may even have to come in for this cardioversion that I just discussed the last segment, back again electively just for a same-day procedure and get zapped again under a little bit of the anesthesia. Don't despair. A lot of times that scar tissue, that burn, as Dr. Kaiser just said, it just takes a while to heal. The procedure is done like a catheterization like we do, and the bottom line is that we usually it's a same-day procedure. You stay overnight just to be watched.
It's very well tolerated.
It is very well tolerated.
Fairly low complication rate. And why it's, if you're getting to a more invasive strategy, why it's a very preferential treatment, because it's so well, it's a surgery, of course, but it's such a minimally invasive procedure with such good results. That's why if you're going to go to that far, then that's kind of the first wave or first procedure that we send people to.
Yeah. So, Dave, a lot of people had success with it, or they had failures with it.
I would say that most have had success with it, but they've had more than one attempt at correcting the problem. And the other interesting piece is that we had a lot of first timers on the support forum that are terribly nervous about having their ablation procedure, and these folks that have had it really, as you have said, it's quite successful, and really share their experiences and have calmed these people down significantly.
Well, it's good that you said about the fear factor. On our line now is a colleague of ours named Dr. Ashish Patel. He's an electrophysiologist from Monmouth County, working at Jersey Shore University Medical Center. And Dr. Patel?
Hi, how you doing, Dr. Eisenberg?
How are you? Thank you for calling in. We had asked Dr. Patel to contribute, and right now we're talking about the radiofrequency ablation, and we have on our line Dave Berger, who's a atrial fib patient, and he's a moderator of a support forum, and we were just talking about the fear factor of going into an ablation. Can you make a comment about this?
Oh, absolutely. First, thanks for having me on the show. I think that AFib is certainly one of the most prevalent and most burdensome problems that our cardiac patients do have, especially from the arrhythmia side. And in terms of management strategy, we always are cautious with our patients when going forward on procedural therapies for the treatment for AFib. And certainly one of the things that we always counsel and spend a lengthy amount of time discussing with our patients prior to making the decision, the very important decision for ablation therapy, is the issue of fear and the fact that this is an invasive procedure, although it's done percutaneously, which just means minimally invasive. It is a procedure, and there are some small risks associated with it, and we spend a lengthy amount of time talking about the aftercare and the recovery, and certainly patients, once they hear and have a conversation with an electrophysiologist, really are put at ease as to how the procedure is well tolerated on a whole, but certainly there are grades to the length and the intensity of the procedure that we do perform for atrial fibrillation.
So who would you be your ideal perfect candidate?
Great question, Dr. Eisenberg. The ideal person in my mind and in the mind, and that is very clear in the guidelines that have been published by the various societies, is a patient who has failed at least one drug or one attempt at what we call specifically an antiarrhythmic. What antiarrhythmics are specific drugs targeted at managing atrial fibrillation. Now, we often use drugs that are used for additional therapies such as hypertension, like metoprolol or toprol, for the treatment of the symptoms of AFib, but they aren't necessarily considered pure antiarrhythmics. So a drug such as flecainide or Rhythmol or Sotalol is a drug that we would consider to try first, and after which that therapy has failed, then they can be considered a candidate for an ablation. Okay. Other demographic factors include age and the presence or absence of having a normal heart.
So, and Dave, you're on flecainide, and you tolerate this very well, correct? Dave? Oh, maybe we lost Dave, huh? Do we have another caller? Oh, okay. Well, so Dr. Patel, your overall feelings about success rates in terms of ablation, what do you feel?
Success rates for ablation really hinge on what you define as success, and that's always been the really the crux of the issue, because it's not defined uniformly just as yet. When we describe success, we talk about having.
I think we lost. We lost Dr. Patel, but we lost Dr. Patel. But hopefully we'll get him back as soon as we can. The major issue that we see is the fact that the patient still has to be on medication after the ablation. That's the major problem, and hopefully we'll get Dr. Patel back on, and he can answer the questions for us about Coumadin. And we're going to talk the next segment about coming off Coumadin, the new replacements for Coumadin, and those are the issues that confront us every single day. Blood thinners. Just because you get a shock, just because you get an ablation, just because you convert, doesn't mean you can come off the medications. And we have a patient that's in the hospital now, and he got valve surgery. As I said, valve surgery is a very common cause, and he just wanted to go home on an aspirin. He still has the irregular rhythm. They can do internal surgeries to do the same thing that Dr. Patel does through the ablation. But it was I had to spend a lot of time in getting him to understand you can't just stop the blood thinner once you've been fixed. It takes a while for that blood to return its sluggishness and to come back online, so to speak, and reduce your risk of having a stroke. Pop quiz. What's the best diet for an atrial fibrillation patient to be on? Atkins, Pritikin, or Mediterranean diet? We'll be right back. Smarter Heart University.